Good evening, delegates. Welcome to today's Kenya Society of Anaesthesiologists hosted weekly webinar. I'd like to thank you all, our audience, for joining us. We have delegates from, not just from us, the host society, but from other specialties and cadres, and often spanning the continent. And we feel highly privileged for this. It's because of all of you and for all of you that we congregate. Our invited speaker, Dr. Maxine Okelo, we thank you for gracing us with your time and insights. I'll introduce her formally just now. The Executive Committee of the KSA for organizing the series, we thank you. And we thank our sponsor, BD, for partnering with us, not just on this session, but on several other ventures, the Kenya Society of Anaesthesiologists and all her members and affiliates, and Ms. Shelmith Macharia, our society administrator, who truly ensures a smooth running of this forum and does a lot of work in the background. My name is Angela Ongewe, and I will be your moderator for this session. I ask again that we keep our microphones on mute and we keep our videos off for the duration of this session. Please write your questions on the chat and we'll have our speaker address them during the question and answer session. For non-KSA participants, please send your name, specialty, and email address as a private chat to the host, Anesthesia Kenya, just so that you can receive your CPD tokens. And as a private chat, just so we can free up the open chat for ease of collecting and collating the comments, questions, and general feedback for the Q&A session. So please note that there are currently no CPD points for nurses and clinical officers. We are engaging and liaising with your professional bodies to this end, but meanwhile, we can and will offer a certificate that will indicate the duration of this session attended if you send us your details as I have outlined just now. Specific for today's session, I ask that we download the apps you see on the home screen, Perioperative Risk Calculator, and Surgical Outcomes Risk Tool. I'll put that down in the chat, and there'll be a chance to participate and learn from our speaker during her presentation. So I think at 6:05, 6:06, let's just jump right into it, and let's warmly welcome Dr. Maxine Okelo. She's a consultant anesthesiologist and a clinical fellow at the University College London Hospital Trust. She's the first Kenyan doing the MSc in perioperative medicine via the University College of London through the Royal College of Anaesthesiologists MTI program. And the University College of London, by the way, is a center, their Center of Perioperative Medicine is one of the world pioneers in this field. She's especially interested in developing educational platforms for perioperative medicine and anesthesia via the KSA, via the Kenya Society of Anaesthesiologists. She's many things, an all-rounder in many things, including and especially fitness and wellness and general mental health. For those of us lacking, I'm one of them. She's a good person to look out for. So Dr. Okelo, are you with us?
Yes, hello everyone.
Karibu sana.
I hope you can hear me clearly.
We can hear you.
All right. So I will. I have been muted. Okay, I'll unmute myself. So I'm going to share my screen. Thank you to KSA for giving me this opportunity to discuss the high-risk surgical patient. I'll try my very best. So I'll start my talk by basically quoting one of my favorite clinicians. Atul Gawande is a very prominent speaker, a prominent author, and a prominent surgeon in the States. Have had a discussion and to ensure basically looking at the well-being of patients. So this is very important because perioperative medicine just does not only look at clinical skills required to take care of patients during their surgical procedures or their surgical journeys as they come to hospital. Also, there are tools that can help you in your clinical practice, and also the idea is to challenge the family as calculators of risk stratification come out in the world. When we use them in our local patients, in the African patients, in the local Kenyan data patients, can we make them better? Can we make them more suitable for clinical patients that we encounter every day? Now, the definition for high risk in terms of what it means from the Royal College of Surgery is high risk patients are defined as a cohort of having a predicted mortality of greater than 5%. So this basically means they've come together, taken down numbers, done studies, looked at audits and papers, and seen that patients who undergo surgery and have, chances of their likelihood of dying is about 5% and above, they're considered to be high risk. But then somebody tends to ask the question, if it means that my patient is less than 5%, does that mean that they are not high risk, or they're not at risk of developing any adverse outcomes after surgery? No, this is basically a guiding tool. It's basically a guiding number. It's not an actual number. And the purpose of having such numbers is basically to kind of identify your patients. When you encounter your patients in the pre-assessment stage and in the perioperative phase, and you actually highlight that this patient has this number of comorbidities, they have this number of problems, they've run into this number of complications, there's a problem that's ongoing that we need to sort out. And the idea is, if we're able to root out these patients from the beginning of the time that they're meant to have surgery, we can actually plan for their care in a way to mitigate these risks or these surgical adverse outcomes from occurring. So it brings about the concept of perioperative medicine. And it's a very wide topic. It's a very wide subspecialty, of which it describes the practice of healthcare being patient-centered. It's multidisciplinary, of which you have different experts and different people from different fields coming together with the patient at the center of treatment, and integrating all the skills and the knowledge that they have, and making sure that the patient is adequately managed from the time the general practitioner or the surgeon tells the patient they're going to have surgery to the time the patient actually has a full recovery. Now, full recovery can actually be very dependent. Lots of us believe that full recovery is when the patient leaves the hospital, but the care actually goes beyond the hospital, because studies have come out and shown that the patients get readmitted back into hospital following surgery, or they actually get more complications after they leave hospital. So the questions we need to ask ourselves are, why are they getting these complications? What can we do as clinicians to prevent people from coming back to hospital? Because coming back means you're pulling someone from the economy, you're pulling someone from their family, you're pulling someone from their state of well-being, and that's just a deficit in itself. So I'm going to start with Mary. Feel free. I think Shelmint has a poll survey that's running, so she'll be giving us questions to answer as we go through the slides. So Mary is a 74-year-old patient. She's got a past medical history of hypertension, type 2 diabetes, moderate chronic kidney disease. She has chronic anemia and ankle edema. Despite these problems, she's been known to cope very well on her own. She uses a mobility scooter to get to the shop, and she's able to manage at least 5 steps by herself when she's at home. And she's scheduled to actually have a total hip replacement. So Mary comes to hospital. She has her elective hip replacement done. It's under general anesthetic. The estimated blood loss is 800 mils. Postoperatively, she's noted to be slightly confused. Pause. Molecular weight is pause. Day 1 post-surgery, she's got low blood pressure, feeling weak, and she therefore has her antihypertensive medications and diuretics stopped. Pause. And she has post-bloods which reveal she has marked anemia. Pause. She's transfused 2 units of blood and she's deemed unsafe to mobilize. Day 2 post-op, she's normotensive, but she has a saturation of 92%. They go ahead and do a CTPA, which shows she does not have a PE. She has a bilateral consolidation, and hence she started on antibiotics for a chest infection. So over the next 10 days, she shows gradual improvement and she's deemed fit for discharge. And she's referred to the renal team regarding her renal function because it deteriorated, and she's given outpatient appointments for her visits. Now, post-discharge, a visitor goes to see Mary and she finds Mary to be acutely ill. She's got shortness of breath and she's confused. So an ambulance is called and Mary is transferred back to the hospital. On arrival, she's noted to have acute respiratory failure, secondary to pulmonary edema, and she's got severe AKI. There's no response to diuretics or any GTN infusion, and she does not tolerate the CPAP, NIV, and hence a decision is made to intubate and admit Mary to ICU. So the question one needs to ask themselves is, from Mary's past medical history, from Mary's state, was Mary's complications, in terms of her treatment, was she well managed? I can see very interesting answers.
It's a nice running pool there, Dr. Okelo.
Very good. All right, Shelman, you can actually, let's give them a couple of seconds so that more people can answer. Oh, it's closed now. Okay, let's go to the next question. All right, so what we can see is majority of the attendees believe Mary was not well managed. Okay. All right, Shelman, let's go to the next question. So was Mary's admission post-discharge avoidable, preventable, or inevitable? I'm curious to see the answers. Okay, so it looks like more than 60% actually believe that Mary's readmission was preventable. Excellent, perfect. Okay, so I'll move on to my next slide. Sorry, just move on to the next slide. There we go. So the question we'll ask is, why is this important? Why are we bothered that we think that she was not well managed? She was not, her readmission was was avoidable. It brings us back to the traditional of surgical care that everyone is used to. We've always had this concept that the patient belongs to the surgeon. The surgeon tells the anesthesia physician or the nurse anesthetist or the clinical officer anesthetist or the registrar anesthetist, as a patient's coming in, they need to be reviewed. Patients are reviewed about a week before surgery, possibly a few days before surgery, or even the day of surgery. And a perioperative plan is delivered at that point in time. Then once the surgery is done, the anesthesia is given, the patients go to the ward. If they're very critically ill, they'll end up in the ICU under the care of the critical care team. And if there are any complications that patients tend to have, it's primarily the surgeon delegating and requesting for consultants and their colleagues to come in and step in to manage this procedure and to manage their complications. And if when it comes to discharge, the patient knows that when they come back to hospital, yes, they do have to see their surgeon, but at the same time, if something did arise, they probably to see, and it just consultants being routed in for different visits, and that might actually be cumbersome for the patient. So with perioperative care, this looks all too familiar. If you look at this cycle, we actually do whatever is on this page. And the idea of perioperative care is coming up with a system that works for the patient. It's coming up with a system that is heavily centered around the patient. What can we do to maximize the patient's physiological and functional capacity to endure the stress of surgery? And at the end of it all, can they go home with a lesser risk of developing an adverse outcome after surgery? And my talk focuses basically on risk stratification, which I think is very important. And most of us always kind of have an idea of how we can stratify our patients. I mean, we encounter these patients, we look at them and we actually say there's something that tells me, or I've used this tool, or I've used this score to actually say that this patient might not actually do well in the ward. I may want them admitted to a high dependency unit, or I want them in the acute room, or I want to just monitor them further in the post anesthesia care unit before they're actually discharged to the ward. The idea of a perioperative system is basically to enable clinicians to weed out high-risk surgical patients so that they're managed adequately. And at the same time, it just doesn't cater for high-risk surgical patients. It also caters for the regular patient. At the end of the day, a patient will say, I went in, had my surgery, and all my needs were catered for, and I feel much better in terms of my well-being when I come out. And even when I'm trying to get back to society, get back to work, I feel that I am much better than how I came in. So where do we start? In the West, they've come up with a couple of studies, and these started a while back, and I'm very happy to say that we have also been in the mix of these studies. The ISOS and the USOS study basically looked at mortality outcomes for patients who undergo surgery in the European countries and also in the UK and globally, so to speak. And just in summary, what these outcome studies showed is that checklists are very good. Checklists work. Checklists help reduce mortality in patients. Checklists enable patients to have better outcomes in surgery. They also did show that just like any other system, any other practicing surgical service, they do have complications and they do have mortalities. And they did show that majority of the patients who were relatively considered high risk never even got advanced critical care or advanced clinical care post surgery, and that contributed to their mortality rates as well. Coming closer to home, the ASOS-1 trial did show that we did have a low risk profile in terms of surgical outcomes, and our post-operative complications were about 18.2%, but we did have a similar mortality of 2% compared to the West. The highlights were infections are the most common issues we deal with, and it highlighted areas that we would work on as a team in terms of increasing physiological surveillance for our patients, making sure we're able to identify deteriorating patients and also improve issues such as access to care. And I believe the ASOS-2 trial is ongoing. I do believe that we do have a number of centers in Nairobi, in Kenya, that are actively involved, thanks to Prof. Ngumi and her team. And that's very great news. I'm actually looking forward to the results. We will be glad to see what the outcomes are. I think before I move on, Shelmy, if you can launch the other question. The question I had was basically, do you believe that we have a local database for surgical outcomes in our patients in Kenya? So so 49% believe they're not sure. Oh, it's actually more than 50. Okay, it's 51%. All right, and 43 say no, and 6% say yes. Okay, perfect. Thank you. That's it. Okay. So in 2010, the National Confidential Diary of Patient Outcomes and Death basically did and did a study to actually look at geriatric patients undergoing surgery, and they were trying to figure out if they contributed to the high surgical adverse effects for these patients. And what they did realize is geriatric patients, because they happen to be a greater majority of the population in the UK and in Europe in general, basically showed that within the first 30 days of having surgery, patients actually perceived that they received good care, but the number was not too high. 36% is not too great. 28% of operations were not done in a timely manner, and less than a quarter of the patients were actually seen as specialists during their stay in hospital. And issues such as comorbidity, frailty, disabilities, mental deterioration, dementia, actually were contributing to the acute illnesses that the patient had and worsening their outcomes. So this basically made the same inquiry team go bigger and ask themselves if this is happening just to the geriatric population, not the general population. And they ended up carrying a national study, which was basically for all general surgical patients undergoing surgery. So it was basically 16 and over in terms of age, and they looked at all inpatients undergoing general surgery. And they identified out of this national that 20% were identified as high risk. And out of those people who are high risk, they contributed to majority of the mortality rates in that group. And then a fifth of the patients who were considered high risk were never even seen in the pre-assessment clinic. And in terms of identifying high-risk patients who probably needed more invasive monitoring or more accurate monitoring, they actually showed minimal use of invasive monitoring techniques in these patients. And their mortality rate was 1.6%, and the high risk was generalized to be at 6.2%. And the degree of surgical urgency in high-risk patients was closely linked to their mortality. And they also had patients who were deemed to be high risk. 4 out of 5 of them never went into the ICU. And 48% of the people who passed on actually never even in terms of care. So the general surgeons decided to come together and decide to and give recommendations on how patients should be managed in terms of emergency procedures. And they've given a recommendation of standards that trusts should generally follow on how patients should be managed when it comes to identifying high-risk surgical patients, the kind of surgery that needs to be done, how they should be optimized pre-operatively, and how they should be followed up post-op. And they just highlight talking about clear pathway plans patients have, making sure that we're able to recognize a deteriorating patient, treat them, and patients should have prompt theater access. We should be able to get risk assessments in all our patients, and those who have high risk delay with their clinical care should have a consultant input. And surgical procedures that have a predicted mortality of above 10% should be under direct supervision of a consultant surgeon and an anesthetist. And then every single stage post-operatively, the team needs to reassess the risk of the patient. And those who've had a predicted mortality of greater than 10% should have at least a bed in ICU. And putting all these things together for them to know that something is actually working, recommend audits. So in the UK, there are lots of audits that are being done, and through those audits, that's how these risk stratification calculation tools have come about. So I'll highlight a few of them. So let's go back to our patient. So Mary is coming in for surgery. We all agree that we need to manage Mary. We need to know what her risk is. So we want to know what's the probability of Mary developing any adverse outcome in the event that she does have surgery. So we would want to have an ideal scoring system. An ideal scoring system is basically a tool that would be routinely available for all patients. It would be accessible to the clinician. It would be easily accessible to anyone who wants to. It should be validated in different populations. That means if it's used here in the UK, it can be used in Japan, it can be used in Africa, it can be used in Kenya, it can be used in Uganda, it can be used in Syria. And you also want a tool that can used in every single demographic. So if I'm going to use it in a neonate, it would be great not to use it in a geriatric patient. And it should actually be able to tell me that, yes, so-and-so is having, and their predicted morbidity or their risk of getting a post-operative complication is 10%, and the chances of dying is 5%. We want something quite accurate. However, we are not able to get an ideal scoring system, so we actually have to rely on the next best thing. So the question we ask ourselves is, what are the next best things? And these include tools that are risk calculators and functional assessment tools such as the MET score or the Duke Activity Status Index, or biomarker assays. And one would ask, okay, I know this information as a clinician, but what value does it provide to the patient? And this basically allows you as a clinician to discuss openly with your patient and tell them, this is what you may expect, this is a possibility of this outcome. And it opens a discussion between you and your patient. And one has to ask themselves, how frequently do I have these discussions? You may realize in some time of your practice, a patient comes to you and said, the surgeon has told me I need to have surgery. I'm not sure, I'm scared, I'm anxious. And such states of mind, much as we think it's just a state of mind, actually people conduct studies and have had, interactions with patients, and actually they say these questions of ways of anxiety actually influence their outcome of their procedures. So for example, in the UK, the SNAP project, which is basically auditing of anesthetic techniques and procedures and services within the UK, and they've highlighted issues such as anxiety and lack of sleep and sore throats to be one of the major things that bother patients when they come for surgery and anesthesia. And they're not even, one would think, I thought you'd be bothered about your case, but they're like, no, I didn't sleep well. I had a sore throat after the procedure. I was generally tired. There was too much lighting. It was very noisy. So it helps you discuss your quality care plan with your patient so that the patient is well, is able to understand what's going on and they're able to make that decision. And it also brings a concept of shared decision making as well. So I'm going to talk about a few of the risk prediction scores, and I'm sure some of you have seen them, some of you have used them in your daily clinical practice, including critical care. And I'll just spend time highlighting interesting ones that I have come across. So at the end of the day, look at it this way. Always ask yourself, this is what they're going in for, what's their risk? And what tool can I use to develop, to highlight their risk? And if I am able to identify the risk, what's the cost to the patient? What does this mean for the patient? Does it mean longer stay? Does that mean longer stay equals more money? Does it mean more money, hence more fundraising? And if I want to mitigate that, what efforts do I have to put as a clinician to actually reduce these surgical adverse? So the surgical risk scale basically is a combination tool of the ASA score and the operative urgency scale, which we've commonly come across and includes the severity of injury. Now, this basically is a tool that has different aspects, and it's been validated in the past, and basically enables the clinician to perform an objective pre-assessment of risk and actually tell them, this is what you're going in for, this is your functional capacity as a patient, this is the kind of surgery that you're urgent, it's urgent, and this is severity of how it is. It's very straightforward. You can easily do this at the bedside. Unfortunately, it does not actually give you a good predictability of your inpatient mortality, because you never know. Anything can interrupt and they'll say, but we didn't know, you just told us it was a mild procedure, it was elective, and such and such. So its limitations are, it includes the score, which is depends on the person actually scoring the patient, and a lot of people say it's hard to use by the bedside, and it's been used in the UK and it's not been used in other systems in terms of patient. but it's very accessible. If you go to the internet, you can just type surgical risk score calculator, and then it will show you what your mortality is. The patient is going through something elective, if it's an intermediate procedure, and the patient is an ASA2, it will give you your scores. Now, surgery-specific risk score is something that we have seen even in training. It's something basically based on your rate of cardiac complication, and procedures are, divided either to low-risk procedures, intermediate risk procedures, or high procedures. So this is very easy to use. The question one tends to ask is, okay, I'm going for a breast reduction surgery. During the case, for example, I'm doing the list with and we realize there are massive blood losses and the patient starts to have massive fluid shifts and blood loss more than a liter. Is that still low risk? Have we moved to high risk? We moved from low risk to high risk intra-op. What does that mean? I had that with the patient that it was low risk. So it also has its shortcomings as well. The ASAA is something that we all are very familiar with, and it's basically assigning a score based on factors which are identified as independent predictors of outcome. And this is subjective. So what might be my ASA2 might be Angela's ASA3, or might be Dr. Kabugi's ASA1, with all jest. And so you have to be it's very hard to actually, tell a patient because you're an ASA3, ASA2, the likelihood of you going to a critical care is very slim. You'd want something that is more accurate. You want something that is more reliable. So this is just a slide showing different categories of what is termed as your functional capacity, just to make it a bit easier for people to familiarize themselves and say, it's easy to say a patient who is poorly controlled it falls under ASA3, and a patient who's well-controlled diabetic is an ASA2 patient. Now, this is my favorite slide. So coming to the UK, I had to accept that I had to deal with geriatrics. I was used to a younger population, and the geriatrics are the most commonly a common group that we actually treat in my trust, and I'm sure in other trusts as well. Now, frailty scores are very important because they tell you the functional state of a geriatric patient. And frailty scores have been shown to actually have a prediction of mortality for geriatrics. Having a frailty score enables you to tell whether this patient is actually going to stay in hospital for a longer period of time or might have complications after they're exposed from surgery. And the value of a frailty score is, yes, I may know this as a clinician, but at the end of the day, I want to involve a geriatrician, or I want to involve an internal hospital medicine specialist with background in geriatric medicine to guide me in terms of what I need to do. If these are patients who we encounter, they have dementia, they're on medications for anti-Parkinsonism, they're giving an anesthetic, we need to know how these drugs interact. We need to team up with a physician who is specialized in this avenue so that they can guide their care. And that guide is not just only pre-op, it also goes all the way into the perioperative period. How will they be managed post-operatively? Things geriatricians are able to see that we are not able to see, and it's quite amazing actually. And more to the fun stuff. As my as the beginning there was POSM, and POSM basically is a risk stratification tool that looks at variables that we can get pre-op and post-op. And from that, we're able to have a prediction. Now, how POSM came about was they actually used multivariable logistic regression analysis and took different variables about patient characteristics. So 12 initially were pre-op, and then they took 6 that were taken. And then they were like, how through these 18 variables, we're able to predict morbidity, we're able to predict mortality. Gone a step further, and now they've said, instead of just looking at bit of a few variables pre-op and post-op, how about we include variables intra-op? And this has generated a lot of discussion. it's a very popular tool that's used here. It's a validated model. Studies have shown that it actually works in the sense that you're able to predict risk, and with that risk, able to mitigate outcomes. The limitations is you can't use it all the time by the bedside before surgery. So there are variables that may need to be played while the patient is having surgery. So you can't say this is a tool I will primarily use before the patient goes to sleep. Then the variables that they also use are quite subjective as well. And it's been shown to overestimate low-risk patients. And some may also say, oh my gosh, this is too much work. They're asking me for too many questions. And variables that depend on how the person taking the patient's characteristics will put it in. So if you're doing a surgery, you're conducting an anesthesia who's known to hands and may contributing to increased blood loss, who's very gentle at the time doing the procedure and hence has minimal blood loss. One has to consider.
Sorry, Maxine, I think we might have lost you. Dr. Okelo? Sorry, audience, I think we might have lost her. Just give it a few seconds to pick up. I can see that she's still connected. I can see she's troubleshooting. I'll ask the participants and delegates, please could you keep your mics off and your videos off so that we can don't have to do a chasing tail. And thank you for joining us. We have a nice whopping number of 233 delegates. This is very encouraging at 6:42 in the evening on a weekday. It is not lost on us that you are taking your time out to join us and to partner with us. And we thank you. Dr. Maxine has a nice interactive session still waiting ahead of her. And I ask that you may stay connected. In this downtime, as she tries to reconnect, I'll ask that in the chat, you just have a look. I have posted some apps that we would like you to download in your App Store, your Apple App Store, or your Google Store, Play Store. This would be Perioperative Risk Calculator. That's one. And the Surgical Outcomes Risk Tool. That's two. You'll find that in the chat. They're easy, free apps. If you download them, because Dr. Okelo will have a nice interactive slot towards the end of her presentation where we can all interact and see how to use these tools. I think we'll find that a very fulfilling engagement. I'm told that we're still trying to reconnect her. Again, we're doing a little bit of cat and mouse on all the mics. Nice. Dr. Okelo, you're back now. Karibu back.
Sorry.
Don't worry. We lost you. Don't worry, we have some participants who I think want to take over your presentation. We like it. It's nice. They're nice and engaged. Again, audience, please mute your mics if you can and keep your videos off. And we have Dr. Maxine, maybe a few slides before is where we lost you.
Yeah, okay. Let me go back. So are we together? Awesome, yeah?
Yes.
Okay, perfect. So I'll go just to highlight the POSSUM. So basically a POSSUM is a very interactive tool. It has lots of variables, and the variables, there's a few variables that are user dependent, and sometimes that has created controversy of its validity, but it's a commonly used tool that's very validated in the sense that lots of surgeons use it. If you go to the internet, there's a website called POSSUM, and you're able to actually key in the patient's buzz and it based age, their physiological state, and the kind of surgery that the patient is actually having, and the risk terms of, does the patient have malignancy? Is it going to be a huge surgery where there's lots of blood loss? And after that, it gives you a score. And the beauty of that score is it's not just one score. It says your morbidity risk is this much, your mortality risk is this much. So they've gone a step further and created an app. And that's one of the apps I hope Angela has managed to share with the family. And just to make it more realistic, in Mary, our patient who is going to have an elective hip replacement. So Mary is 70. She's got no cardiac failure. She's got no history of dyspnea, and she's got a normal ECG. Systolic pressure is between 110 and 130 with a rate of between 50 and 80. Her HB was, I think, 11, and she had a white cell count of, I think, about 4, I can't remember. And she also had urea that was less than 7.5. Her sodium was 131, and she had her potassium of, I think, 3.4, and her GCS is 15. She's coming in for a complex major operation, and it's just one procedure, and we said her estimated blood loss was 800 mils. So if we are to calculate her morbidity estimate, it's 69.2%. So the predicted chance of Mary getting post-operative complications is about 70. The mortality risk is about 6%. So technically, she's a person who, in your practice, would be more, one would say she will not go to the ward immediately. I'd want to keep an eye out for her. So in systems that do work, they do recommend that, you know, patients should require more closer vigilance and monitoring through the consultant anesthetist and the consultant surgeon. But I always say that this is something that will work well in the West. If we're in a situation where we are pressed in terms of numbers, our nurse to patient ratio, our doctor to patient ratio is quite wanting, then this would not apply. So my question to the team is, as we get to know about these risks, what can we do knowing that we have such apps? How can we make them function for an environment that we are usually accustomed to? If we are not in a situation where we can easily access critical care beds, what can we do to make the situation better? Do we have to involve internists? Do we have to involve the nurses to be more practical in terms of keeping an eye out for these patients? Do we have to, you know, create something like a mini rapid response team that would check on such patients who are in the ward but, you know, are at high risk of developing complications? So it's all about asking yourself, this is what I have as a tool, how can I make it work in my environment? Now, there are medical risk prediction tools that have been used in the surgical field, such as Apache, which we commonly seen in critical care. And we've also seen the Charlson Comorbidity Score. Now, this is a very old score. It's been used for a long period of time. And basically, the Charlson Morbidity Score is a score that people use to actually predict your 10-year or 1-year survival rates. And it's accessible on the internet. That's just a brief look on how people use the Apache 2 scoring system. I don't know if it's used, it's not used here. Maybe I don't know if it's still used back home. The Charlson Comorbidity Index basically asks you a series of questions, such as your age, if you've had an MI, if you've had a history of heart failure, have you had a CVA or a TIA? Is your patient with a history of peripheral vascular disease? Do they have COPD? Do they have connective tissue disease? Have they suffered from a peptic ulcer, or they have liver disease? Is it diabetes? Are they hemiplegic? Do they have chronic kidney disease that's moderate to severe? Do they have a malignancy? Is it local? Is it metastatic? Is it a leukemia? Is it a lymphoma? And do they actually have AIDS? So once you key in all the data, you're able to tell the patient the estimated 10-year survival. So, you know, sometimes one asks, will they want to know? Sometimes they want to know in order to plan their affairs, especially if they have a chronic debilitating disease. So it's something worth considering. Now, the surgical outcome risk tool is something that is locally developed. Basically, it's It's a tool that has been done by one of my research supervisors called Professor Ramani and Joseph. So basically what they did is they looked at the data from the inquiry of patient outcomes and death, and they said, how about we get a risk prediction tool for mortality to see what the likelihood of dying is within the first 30 days of surgery. And they said that include all patients, Excel provided. If we use it for a patient, I already did it already. She's Mary coming for bone surgery. It's very specific. It asks you which procedure that Mary is having, and then you move ahead to say that it's a total hip replacement. And moving on to the next category, it's very short, it's very quick. So we know it's a primary total hip replacement with or without cement. It's a major complex procedure, and the patient is ASA3. It's an elective procedure. It's not thoracics, it's not GI, it's not vascular surgery. It's not because she has a cancer and she's 71 years of age. And basically you can have a discussion telling Mary the chances of you dying is 0.82%. So you might have that patient who you'll ask, does a number mean anything? And you say, no, it doesn't, but it means something for me as a clinician. It means something that I will need to do, or there are things I'll need to make sure I do to make sure that you don't fall within that number, however small it looks. So NELA is a very interesting concept I thought I'd just share with the group. And it's basically an audit activity that's done here through the Royal College of Anesthesia and a number of partner groups, basically looking at how anesthetic and perioperative medicine and care is given to patients. Now, they decided to do an audit and ask themselves, what is the mortality rate of patients who undergo emergency laparotomy procedures in the UK? They took a number of hospitals, they did their study, and they actually realized the mortality rate is 15%. And this was actually very shocking and alarming. So they said, no, 15% is too high, this has to stop. So what they did is they created an initiative, and basically they said, we have to create standards and create pathways for teams to use in their institutions, however rich or poor, because there are some poor NHS trusts that they can utilize to make sure that we can reduce the mortality risk. So lots of people are initially hesitant about this because it's a lot of work. It means that every single emergency laparotomy patient has to be put into this database. That is emergency laparoscopy, emergency laparotomy. And they're gonna ask you specific questions. And through those questions, they're able to tell you how the patient should be managed. So for example, if you use the PPOSM score, which they basically borrowed and made it the NELA score, they actually tell you if your patient has a morbidity risk of greater than 10 to 15%, your patient should actually be admitted into a critical care unit, managed with basic care, critical care monitoring, managed and then downscaled to a ward. So I don't know how this works outside other trusts, but I can definitely share what happens in my trust. So in my trust, the NELA is under the perioperative medicine docket. So what happens is the anesthetist on call reviews a patient who is coming in for emergency lap, and this could be the registrar on duty. They notify the anesthetist if their PPOSM score, their NELA score is very high. The anesthetist has to come in and they have the discussion with the patient about their risk. And then the surgery is done and the patient is admitted to ICU. Depending on how long and how well the patient does post-critical care, they are downscaled to a ward. And in the ward, that's where we come in as the perioperative team. So we manage the patients until we feel they're fit for discharge off the NELA reviews. And it basically means teaming up with geriatricians, internal medicine specialists, the hematologists, the microbiologists, the physiotherapists, the dietitians, and we conduct multidisciplinary meetings every Thursday to discuss the patients that are on the list. And we ask questions of, are they on appropriate antibiotics? Are they going to stay on antibiotics for another 7 days? What did the cultures grow? Should we change the antibiotics? Are they walking? Are they drinking? Are they eating? Are they do they have good analgesia? Are they mobilizing? Are they sleeping well? What's their comfort level? It sounds like it's a whole bunch, but it's basically registrars who come together and notify their consultants if there are any glaring issues that need to come up, need to be highlighted. And they found it to be beneficial. So they've realized with conducting the NELA audits, they've realized that their mortality rates have gone down. So for example, in UCLH, their mortality rate for emergency laparotomies was 11%, and now it's down to about 9%. So the NHS has gone further to say, if you're able to reduce your mortality rates, we'll fund you more. And that provides incentive for these people to get more indulged in doing these activities. So the next score is the NSQIP surgical risk score. And I think this is my favorite score out of all these scores. And it's developed by the American College of Surgeons. And what they did is they basically took 4.8 million cases and from the past and looked at all the outcomes that the patients had. And they developed 20 characteristics of these patients and created a statistical model. And from that, you're able to actually tell what kind of complication the patient will get perioperatively within the 30 days of surgery. And they've gone even a step further to actually tell the patient the predicted length of stay. And I think this is more specific compared to the other calculators because you're able to tell the patient, or they're able to predict your chances of getting pneumonia or any cardiac complications, if it's going to be a surgical site infection or a UTI or a VTE or renal failure, what's your risk of readmission, the risk of you going back to your OR, the risk of death or being discharged to another facility. It's something that's available online. All you need to do is key in the kind of procedure that you're going in for, and it will give you the results. Moving closer to home, Madiba Bikad et al. Came up with the ASOS 2 calculator. And basically, it's just highlighting the urgency of having a method of post-operative surveillance. So if we're able to actually use the parameters of age and ASAA, surgery timing, surgery severity, knowing the indication for surgery, the type of surgery someone is going in for, we should be able to come up with a score. And if it's a high risk score of greater than 10, then we know what to do in terms of clinicians. This patient will probably need to be monitored more closely. There will be more need of intervention intraoperatively or postoperatively. So like I said, risk assessment is not just something you do before surgery. It's something that is ongoing until the patient actually leaves the hospital. The revised cardiac risk index is something that we have commonly encountered, especially from patients who are known to have cardiac disease going for non-cardiac surgery. And it's very simple and easy to use. And it's basically highlighting if you have any of these 2 risk factors, you're deemed as high risk. And that will basically mean, as a clinician, I am no expert in cardiology. I'll call the cardiologist. And my question is, how do we make the patient better? How can we improve their physiological status? If they have heart failure, what can we do? If they have cerebrovascular disease, what can we do? If they're poorly controlled diabetic, the diabetic team need to come and optimize the sugar so the patient has a better HbA1c. So the end of this all is you have to ask yourself, how useful is the tool to me as a clinician? And how accessible can I use it and apply it in my daily clinical life? So I'm going to pose this question, and this question, I think it would be best if we get the answers during the Q&A. But if you were able to actually download the app, feel free to just put your answers in the chat group, and so we can actually see what your risk calculation was. And it's basically about a patient who is 70 years of age. She's about to have bowel resection surgery for colon cancer, so that's a malignancy. She's got a history of chronic atrial fibrillation, and she's got mild COPD. And the chest x-ray that was done shows cardiomegaly. She's got a BP of 161/90. Her ECG shows a rate control of AF of 85. And she's got a HB of 11.2, a white cell count of 8, urea of 7.8, low sodium of 151, and Ks of 3.3. and the estimated blood loss is 400 mils with a likelihood of minor peritoneal soiling. So the question you ask is, what's the mortality risk of this patient within the first 30 days of surgery? What's the chances of her getting postoperative complications? And knowing that, what would you do as a clinician? What would you do in terms of telling the patient about their risk of complications? And who should you involve in the care moving on forward? And what would the aftercare of the patient be post-op? So those are the questions I'd like to generate amongst the group, and then we can discuss them towards the end. Now, moving on from scores, there are just functional assessment tools that we have, and these are very easy. You can provide them in form of paper, or you talk to the patient and tick, and they are able to participate in their own assessment. And the DASI score is basically a score asking the patients, what can you do? What's your level of activity, and what's your level of well-being? And through that, you're able to get an equivalent MET score, and that kind of gives you an idea of the patient's functional capacity. This is subjective, of course, it depends on the patient. So one would tend to ask, is there anything objective that would help the patient? And that brings me to CPET. So CPET is something that's it's not new, it's not old either, but CPET basically means it's cardiopulmonary exercise testing. And it's basically a very objective test that wants to know what your cardiac and respiratory capacity is like. So what happens is patients are put on a treadmill or a bicycle, and you have a cardiologist or a technician who's been trained in this to basically stress you to see how well you will handle the stress of exercise. And from that, they're able to get things like your anaerobic threshold, your lung function capabilities, your lung function capacities, and also see whether you generate any ECG changes that would worry or would actually show some suggestion of any ischemic problems that occur. We do this in our institution. So as a formality, all patients who undergo major surgical procedures do this. And these are results that are provided to the physician before. So in training of periop, there's a module where you actually have to learn about CPET, because as a perioperative physician, you should be able to interpret the results and then have that candid conversation of your patient saying, you have a very low anaerobic threshold that tells me the chances are that you may need mechanical ventilation post-operatively, or you may need more close follow-up post-op, and I may have to indulge the physiotherapist to be a bit more rigorous with you so that you can actually indulge in proper chest breathing exercises. Moving on from functional assessments, we come to basic blood tests. Now, the issue with basic blood tests is one tends to ask how available and how affordable can they be. Now, troponin levels have been shown to actually be associated with predicting your 30-day mortality, especially in patients undergoing non-cardiac surgery. And just having a clue of how your troponin changes, especially if you have patients who start complaining of cardiac symptoms post-op, that will kind of give you a rough idea of what's going on so you can intervene. If you have a patient who you suspect to have heart failure, you can do tests like the NT-proBNP to actually see what their baseline levels are. And then as they're recovering, or probably during their recovery course, they're not getting any better, you're able to actually assess the patient and see whether this patient actually has heart failure or is going towards heart failure. Because as we know, surgery and anesthesia trigger an inflammatory response within the cell. So studies have come out, and lots of studies are showing that if you do troponin T testing, you do NT-proBNP, or you actually take CRP levels, you're able to tell what cardiovascular event patients you might predict the chances of any cardiovascular event occurring. And what the societies have done, the cardiac societies have done, have basically said, yes, with all these studies that are about, this is what needs to be communicated. One, it's very important to do risk stratification. We've seen that it works. they've gone on to even recommend doing the NSQIP model, which is the American College Risk Tool, or the Cardiac Lee Risk Index Scoring Tool, to actually evaluate cardiac patients who are undergoing non-cardiac surgery. They've said that we can consider doing troponin levels for patients who are high risk for getting cardiovascular events before surgery and 48 to 72 hours after surgery. This is conflicting because some studies have come up and shown that that means nothing. NT-proBNP and BNP measurements can be considered, especially for prognostic determination of events post-op for high-risk surgical patients. And they do not actually say that you should routinely take blood samples to do testing of these biomarkers, just to say, I need to know what of death is or your risk of morbidity is. So all this is information available for you to decide how you'll manage it. So at the end of it all, one has to ask themselves is, I have my high risk patient, what am I going to do with them? First of all, the patient needs to know how and why they're high risk. And once they're aware about how and why they're high risk, as a clinician, you need to develop a care plan that's suitable for the patient. And when you're developing that care plan, you may have to involve people who have more capabilities in certain fields to optimize the patient's care. And you, as a perioperative physician, or the clinician managing the patient, has to be the center of communication, because the hematologist will not know what the cardiologist has said, and the surgeon will not know what the hematologist has said. But you, as the anesthetist or the person providing the anesthetic, will get all that information, and then you can actually provide feedback and make the necessary actions that need to be done for the patient. And as usual, as the anesthetist, the only person who's allowed to clear the patient for surgery is the anesthetist. So the following slides are just basically examples, because they're just associated with the clinical history that I gave with the patient. So in the Google and internet are friends. There's lots of information regarding guidelines about care and perioperative care. It's information that I'm willing to share as well. So there's a British Society of Diabetes that basically have a booklet describing how to manage patients during the perioperative period. And for example, in our institution, when we see our patients in the pre-assessment clinic, the pre-assessment nurse knows that if their patient's HbA1c is greater than 8.5% or greater than 69, they're not even seen by their nurses, they're automatically sent to the team. And for example, once you have a poorly controlled diabetic patient, they are educated, their sugars are optimized, and a discussion must be had with the diabetic teams and patients regarding follow-up care and post-operative care about their diabetic management. When it comes to issues such as cardiac risk, where cardiac patients undergoing non-cardiac surgery, there are guidelines that are available from the AHA and the European Society and the Canadian Society as well, giving guidelines. I don't think there are any recent guidelines. Some have interesting, conflicting, suggestions. So it's always interesting that it can be a forum for discussion where you look at what the Europeans say and what the Canadians say and what the Americans say, and then say, how about what the Africans say? So that's another thought-provoking. We should also come up with our own guidelines because we have our patients as well. The cardiac risk index is also something to help with care. If you have patients who have the following comorbidities, referral to the cardiologist is very important. Our patient was anemic. People wonder, HB of 10 is not too bad. HB of 11 is not too bad. They can manage as long as they're not bleeding. But how do we know? So what does that mean? Is it an issue of low blood? Is it an issue of nutrition? Is it an issue of thalassemia? What if they're sicklers? What needs to be done by that? What if there are patients who have severe multiple comorbidities? What's my threshold to transfuse? What's my threshold to ensure that they have normal B levels in order for me to clear them for surgery? Be it an elective procedure, be it an emergent procedure. And there are guidelines basically telling, describing what can be given if it's issues such as iron deficiency and the value of intravenous iron, or taking oral iron. And so, for example, if you find a patient who's got nutritional deficiency, iron deficiency anemia, you might want to send them for an iron profile. You want to know what their ferritin levels are.
Yeah.
And if an issue of other issues like vitamin B, you want to know what their B12 levels are, what their folate levels are. Is it because of malignancy? Is it because of their drugs they're using? Is it an endocrine issue? Is it renal? So you have to kind of learn what anemia the patient has and see how to manage it. And managing it doesn't mean you have to do it by yourself. Managing it doesn't mean you have to send a patient to a hematologist. Sometimes that may work, sometimes that may not work. Sometimes it just may take a phone call, and they might guide you on how to manage the patient. They might suggest these are the following ways. So you can see the element of different specialty teams coming in to manage the patient. Which patient will automatically need a transfusion? Which patient will, need blood on standby? And then doing all these things will make one ask, okay, so we're optimizing HB. What's the outcome? Is there any benefit? Has it shown to actually reduce morbidity? Has it shown to actually reduce mortality? Those are the next steps, after getting to manage patients. If you have patients who are on oral anticoagulation, or if they take heparin or warfarin, what are you going to bridge them on? Especially maybe they need to be on those oral anticoagulation medication. What are you going to bridge them on? How will you bridge them? Sometimes a phone call to a hematologist would help. There are guidelines on the net regarding bridging mechanisms. I always see posts from Lee and talking about anticoagulation and regional anesthesia. So this is information that's very easily accessible and ready for use within practice. If you have patients who are obese, just doing a stop bank questionnaire in your pre-assessment gives you an idea of this might be a problem post-op. This might be a problem in the sense that the nurses might call you in the middle of the night saying so-and-so is not breathing. So would I want such a patient in the ward, or I'd rather have them in the HDU on an NIV just in case, because they might have sleep apnea. They do have an algorithm to follow. For example, if you have a suspected patient with obstructive sleep apnea, giving you suggestions of what to do. I will not lie to you. I think I saw my first sleep study when I came here. I just read about it. So, there might be resources that are unavailable back home, but that doesn't limit us from treating the patients. We have capable, very well-skilled respiratory physicians. We have lung function tests that are available that we can use. We can actually still manage our patients despite not having extra that would facilitate more definitive care. And with all that being said, my take-home message basically is, it brings me back to a very important statement that Dr. Thika would tell us when we were doing pain. When you're managing a patient, you always want to look at the biopsychosocial aspect of the patient. And when you do that, you are able to actually assess the patient's risk and identify what will actually make the patient get worse. And as a clinician, once you've identified what is going to make them worse, then you need to make sure you can mitigate that risk and involve different people to help you mitigate that risk. Always keep your patient up to date, well informed, allow them to allay their anxiety and fears and concerns and their thoughts regarding their procedure and their care. And from there, you can actually develop a care pathway that eventually suits all patients. So I think that's it. My presentation is done. I'm sorry I took so long.
Not at all. Hello, hi, Maxine. Thank you. That was an excellent. Thank you for honestly a brilliant presentation. Thank you. It's extremely pertinent, and I have questions of my own, but I can see that it's, well, I'm going to wait for the questions to come rolling in. We'll chip in and discuss some things as we go along. Thank you for your time. That was a very well prepared and brilliantly delivered presentation, and we'll tackle some of the issues or the questions that may generate after. But before that, I'll quickly welcome Edwin Bore. He's a territory representative, East Africa, Medical Delivery Solutions, BD. These are our sponsors for this session, who have been very generous. They've partnered with us before, and he would like to deliver his presentation on vascular access options. Welcome, Edwin.
Thank you for the invite. Let me know when you can see my screen.
Okay. We see your screen, Edwin.
Okay.
Awesome. Thank you.
All right, I'm going to be very brief. I know time is not on our side, but I'm going to be very brief and just straight to the point. So as I've been introduced to today, I would just like to put our focus on vascular access options, which I believe is an area of interest for most of us, particularly in this COVID era. But before I go to the vascular access options, allow me to just project this slide on spinal needle, which I believe is an area of interest to most of us within the anesthetist, particularly for regional spinal anesthesia. We are one of these companies that are the pioneers when it comes to spinal access options. So BD is, when I talk of vascular access options, we are playing around the area of peripheral and what you call the central vascular access. In our peripheral vascular access, we are the company that was the first one to introduce our safety options, because we had the healthcare workers' safety in mind, and we did introduce the cannula with a safety feature so that we can try to mitigate the issues of needle stick injuries. So since the introduction of the safety, the cannula with a safety feature, we have indeed seen, reduced cases across the globe of needle stick injuries, which is a plus in terms of safety that we want to have within our practice in healthcare. The next thing that we are looking at in our peripheral vascular access, particularly for the pediatric cannulation, is the introduction of what we call the InstaFlash technology to the cannulas, which is basically designed to try and reduce, or rather increase our first prick success, or rather increase our success rate when it comes to pediatric cannulation, because we believe that pediatric cannulation, or that population, is usually what we tend to refer them as a difficult cannulation. And with the introduction of the InstaFlash technology, we have seen first attempts a success rate going higher, and we believe that this is the technology that we can incorporate within our setup so that we can increase, or rather we reduce the missed opportunities in terms of cannulation. So basically, that is the new development that we have put into place in terms of peripheral vascular access, both in our adult and peripheral, or rather both in our adult and pediatric cannulas. The main area that we would like to just put a bit of emphasis today on is on our central vascular access. So in BD, we are advocating for what we call the PIC. PIC is an acronym for peripherally inserted central catheter. So this is how PIC looks like for those who can see, the anatomy. It is a relatively long line that is inserted peripherally and goes all the way to the to the central line. It terminates at the lower third of the superior vena cava. So in every respect, it is a central line, and we are currently offering a very comprehensive online program for those who are interested in learning about the insertion of the PIC lines. However, just allow me to go through the take-home message of the brief nutshell about the PIC lines. In terms of insertions, these are the three most common veins that you will use for inserting, or rather for getting the PIC in. We use the basilic, the brachial, or the cephalic veins. As I said, these are deeper veins. Being deeper veins, it is not a sheath technique. The Seldinger and even the modified Seldinger, these are some of the techniques that a PIC would be applicable in terms of insertion. And again, as I've said, once you have PIC in, you need to certainly we can use it for blood sampling, means you can collect blood from the PIC and use it for sampling for different purposes. Of course, you can use PIC to give infusions like any other line. For contrast, power contrast, then you don't need to get into another line. We can still use PIC for power injection of contrast medium. For CVP monitoring, I believe most of anesthetists in ICUs and so on will be doing a lot of CVP monitoring. PICs can be used for that particular. We believe PICs in terms of clinical settings are very robust because they can be used in a variety of clinical settings. In critical care, ICUs and HDUs, then we can use PICs in those kind of settings. We can use PICs in wards. Patients who are in wards, PICs can be used. Even in doctors or clinicians' offices, they can be. In outpatient settings, we have had in Kenya, number of patients getting to use PICs in just outpatient. Patients would be having the PICs in them. They'd be just coming for frequent, their clinical sessions or other chemotherapy sessions and going. And so PICs can still be used in that kind of setup where patient can be having a line and it coming back. And that has been one of the plus points of why we should consider PICs. And of course, even in home care setting, patient going home for different kind of reasons and they need to be coming back to the hospital for checkup, then PICs can offer that sort of a solution for us. Let me just highlight one of few things that you might want just to know about the PICs, that they do come in different types. You can have PICs with different configurations. So we have PICs, for instance, if you have clinical indications to use a single lumen PIC, then they are available. If you want to use a dual or 2 lumen PIC, they are available, or the triple 3 lumen PICs, then they are available in our setup. They come in a variety of length. As I've said again, it is a very long line that you can trim to the desirable length that you want. And so a length that is between 45 and 60 centimeters, but you can trim to the length that you want to use, for which varies from patient to patient. Indications are. In terms of design, this is important for us to just note that we have PICs. If you can see the first image, they have the clamps, and the other PICs have what you call the valves. The second PICs have what you call the valves. So that is just the options that we are also offering in Kenya and indeed East Africa. We're planning to move around East Africa. This is just important to note that if you have PICs which have clamps, then in terms of care and maintenance, they are locked with heparin. If you have PICs with valves, then in terms of their locking, we use the saline leak. So we have both options of saline lock PICs and of course the heparin lock PICs. So again, those are the options which are available for us to be able to consider for our patients. In summary, I believe that PICs is very robust practice, as I've said, in terms of their relative ease of insertion and the cost-effective insertion. Looking at the duration which PICs can stay in situ vis-a-vis the complication rates, which are a bit low, becomes a very relative practice that we might want to consider for our patients. It can be placed in a variety of different treatment settings. So we have bedside patient settings within the bedside. We have, it can be inserted in the bedside, in the doctor's clinics and so on. And so brings this variety of, can be used in different settings. It can be used for different purposes and so on. And of course, the care and maintenance, as I've said, the PICs can stay long based on the care and maintenance that is given. And so this care and maintenance that I'm talking about is a relatively very easy support that we are giving. PIC practice in Kenya is not, indeed East Africa, let me say, is not a very well-developed practice. We believe that the anesthetists are key stakeholders, people who hold the key to this practice in Kenya and Africa. We're looking forward to building some partnerships with your members to be able to build this practice and be able to move it to the next level for the benefit of our patients. So, we're looking forward to engaging you and working together towards building this practice to the next level. I think that would be the end of my presentation. So basically, we were just looking at vascular access. I think that was the key point, the safety in terms of vascular access, and of course, peripheral vascular access safety options, and of course the central line access in our advocacy towards the PIC line in terms of the central line access. So thank you so much for having us for this session.
Thank you, Edwin, and thank you, BD. We appreciate your partnership. Thank you for providing this platform, sponsoring this session for us, this learning. And definitely vascular options is not at all far removed from Dr. Okelo's presentation today. I think Dr. Okelo has been a beneficiary of some training in PIC lines herself. I think she might be one of the few truly trained anesthesiologists in Kenya in PIC lines. And that's a coincidence, yes. Thank you, Edwin. We look forward to working with you. Thank you for your support.
Okay.
Okay, so Dr. Maxine, you're still online?
Yes.
So I have a question coming in here, Maxine. Okay, first of all, the feedback is blazing. The adjectives I'm seeing are awesome, lovely, wonderful, great, brilliant, informative, timely, appropriate. And I know I'm usually very effusive, but honestly, this is has been a wonderful presentation. Clifford iPhone says, great talk, Maxine. And he asks, any chance AI, artificial intelligence, could be used in perioperative care in your estimation?
I think so. I just don't know how. I think so. So where I work is a thoracics and urology center. So when I joined UCH and I went to theater, I saw the team using robotics to do prostatectomies and cystectomies and ileal conduits. So I think there is room for AI. It's something that's popular. It's something that's coming up. I think I work in a paperless trust, so definitely it's something that's worth exploring. And I think if we're able to innovate anything that would be able to tell risk assessment or give some in-house information about the patient. For example, I think the Americans have come up with something called flow track that seems to be used for cardiac output monitoring. That's a bit more specific than esophageal Doppler monitoring, and moving away from things like the LITCO and LITCO. So I think there's definite room. So I'd throw it back out there. If there are any geniuses who can think of ways, most definitely it's worth an option of trying.
Absolutely, absolutely. I don't think I can add anything to that. I agree wholeheartedly. So Maxine, some things really struck me, and I mean they're intuitive and obvious. But I loved how you said that what that when you risk stratify and you come up with a percent, where a patient might ask, what does that mean to me? When it happens to me, it's 100%. If it doesn't happen to me, it's 0%. I like the way you hit home and said it means something to us as perioperative physicians and our decision making and our planning. So that's quite informative. I wanted to ask you, maybe I want to ask broadly about the entire NHS, but certainly in your trust, how do you handle your high risk surgical patients post-operatively? So how far forward do you follow them up to discharge? Or do we fall off some way before? What do they consider ideal practice on following up patients and even after discharge? Do you know what happens to your patients?
Okay, so for example, in UCH, how the perioperative pathway works was based on a student's PhD. So what happens is a patient is identified through screening tools in the clinic. And this is done by the pre-assessment nurse. So because they believe that the perioperative or operative nurses and critical care nurses have the ability of actually identifying high-risk surgical patients. So as they review their patients, they're doing checklists. And that's, the whole concept of checklists. What can I, elucidate from this patient that tells me they're high risk? Once they're high risk, they identify what makes them high risk. Is it issues like anemia? Is it their heart condition? Is it the fact that they're coming for a complex major procedure? Once that is done, they involve the perioperative physician. So the perioperative physician comes in, reviews the patient. It could be face-to-face reviews. It can actually be note reviews. With COVID era, it's phone calls and video calls. And then investigations are done. Once the investigations are done, more information is added up. More information about the patient comes out, and then we start to liaise with other teams, the hematologist, the coagulation specialist, the cardiologist. Interestingly enough, there are NHS experts in my trust who have an interest in perioperative medicine, so they're specifically dedicated to managing patients who are coming for high-risk surgery. Once they've done their optimization, the patient comes into theater, they meet their anesthetist, who then also is aware about the patient's high risk, so that they come up with a plan that, makes sure the patient, has a smooth, more or less safe anesthetic. And the patients are admitted to what we call a post-anesthesia care unit. So most PACUs would probably be a recovery room in Kenya, but in our setup, it's actually an ICU. And it's basically 9 beds in one trust and about 16 beds in another trust. So we end up oscillating between the two. So you review these patients for a period of time, and the team consists of critical care specialists, and you have a geriatrician, you have the dietitian, the physiotherapists, you have an intern. If you need to bring in other experts, they come in. Patients are followed up and discharged. When they're discharged, they are followed up in the unit by the perioperative doctor, who reviews the patient for the first 3 or 4 days after surgery, after being in the PACU. And basically just to make sure things are done. The microbiologist is on board trying to make sure that antibiotics and antimicrobial stewardship is well maintained within the trust. And then the geriatricians are involved, the surgical team is involved, and then there is what we call the rapid response team. So these are part nurses who basically keep an eye on the patient and highlight to the critical care team or the periop team that there's something off with the patient, because they communicate with the nurses and they see the patients in person. They're able to do rapid assessments, they're able to do BGAs, they examine the patients and ask for specific tests. If there are things such as hypokalemia or issues such as hyponatremia, they manage as they inform you. But if they feel that the patient is getting worse or their mu score is getting worse, they actually highlight you, and they might actually tell you this is a patient who may need more critical care. If all goes well, they're discharged, but they're discharged with the input of the geriatrician if they're elderly, or the surgical patient. As the periop team, we give recommendations regarding their discharge, and then the discharge is also provided to the general practitioner, who kind of makes sure that there things, either some instructions are followed or not. This sounds so wonderful, it sounds so smooth, but trust me, it's not. Every system has its flaws. There are people who sometimes don't think it's necessary. There are some few interesting surgeons who feel it's a waste of time. So you'll get the necessary opponents to the flow of structure, but in cases that it works, in cases where surgeons are heavily involved, it does work. And in our trust, we have something called a follow-up clinic. So it's a follow-up clinic. It's basically a critical care follow-up clinic for all patients who've actually undergone any form of critical care exposure. So you see them after 1 to 2 weeks, and it's basically a critical care intensivist with a psychiatrist or a psychologist and a nurse, basically finding out how the patient is doing, dealing with issues such as anxiety, getting back to the community if they're not sleeping well, dealing with the trauma of surgery, the trauma of ICU, the trauma of being pricked and poked and broken ribs, things like that. So it's a system, but they usually have the option of always alerting the perioperative team in case they need to intervene, but it's a work in progress.
Thank you, Maxine. That's very clear. Thank you. That's a nice, concise, and contextual and very honest answer. We just have Yik I think 7 minutes before closing. Let me just quickly do 2 questions. Larry Cisse is asking, what are your comments on chlorhexidine bathing for high-risk surgical chlorhexidine for high-risk surgical patients as far as preventing surgical site infections? If you have a comment about that, if anything is happening in your trust.
So there is chlorhexidine washing, there's Hibby scrub use, and we use something called Perioperative here. But in terms of surgical site infections, it's a bit more specific than that, in the sense that if you have a patient who's high risk, so for example, urology patients tend to have frequent UTIs, or these patients who have urology malignancies tend to have some element of infection. So the microbiologist is involved from the beginning of the pre-assessment clinic. So the microbiologist, you know, upon looking at samples and cultures and stuff, recommends the specific antibiotics. They talk to the surgeons about their surgical incision and making sure that the sterility, of course, their standards within the hospital. But the main focus that they use in preventing surgical site is basically technique from the surgeon, the sterility in theater, and also the use of making sure that the proper antibiotics are used for the patient, because like ChloraPrep are standard for all surgical procedures.
For all surgical.
Yes.
Okay. Dr. Omani asks, are ACE inhibitors still prescribed preoperatively, or are they stopped in antihypertensives? In your setting, basically ACE inhibitors.
So that's a good question. So ACE inhibitors are stopped at least 24 hours before the procedure because of the fear of vasospasm syndrome intra-op. There's also literature, I think, in the Cardiac Society regarding use of beta blockers as well intra-op. I'd be glad to share the information. And then post-op, we basically look at how the patient responds because of the surgical hit, the inflammatory response. We don't just restart ARBs and ACE inhibitors right away. If it's a patient who's on a beta blocker for maybe, let's say, the rate control AF, we start low dose and slowly graduate to the original dose, because we tend to realize that most geriatric patients tend to become a bit hypotensive post-surgery, and it's not just because of their physiological response. There's also an issue of goal-directed fluid therapy. It's very hard to kind of get that balance. So you might find that there are patients who, don't get enough fluids intra-op, and then there are, the thoracic patients who do the one-round ventilation, and the anesthetist is very careful about their fluid management intra-op. So hypertension is a very common complication or a common side effect we see from surgery. So we don't start them right away. So yes, stop them 24 hours post. Yeah. Before.
Some questions are around COVID, Maxine. Prof. Chokwe, Dr. Ngugi, Lee, Winnie, sort of asking about COVID. So I'll try and minimize, compress them because of time. So has COVID sort of affected the tools that you use for risk stratification? Does it have implications or not quite? For your outcomes, are surgical outcomes worse in COVID? Do your patients get tested, or do all your surgical patients get tested for COVID before going for surgery in this era? Maybe let me hold it there for you.
Great question. So COVID definitely has affected the whole flow of pre-assessment and review of patients, most definitely. So reviews are done on phone, reviews are done through face-to-face. So that makes it difficult, especially if you have that very sick, ill patient that you want to see face-to-face, because there's only so much a video will show you. When it comes to optimizing the patient, we're no longer doing cardiopulmonary exercise testing because of COVID. When it comes to preparing the patient before surgery, the patients are actually mandated to isolate by themselves for 2 weeks before surgery. So they do have a COVID test 6 weeks before surgery. They do have a COVID test 2 weeks before surgery. And then when they come into the hospital, they do have a COVID swab test. And then they have a COVID test post-op, because we just also want to make sure that the healthcare worker do not give the patient COVID. So there are lots of gaps in the sense that hands-on, activities are a bit limited in the sense that you're not able to examine patients. It was interesting not using a stethoscope for a very long time, and we still don't. They don't recommend using a stethoscope. Has it worsened complications? Most definitely, yes. The cancer cases have definitely gone up. Many patients have not been able to get their chemotherapy, so there have been lots of mortalities. Unfortunately, also when it comes to issues such as obstetrics, many women are getting complications because they're too scared of going to hospital. We've had a huge number in emergency laparatory because people stay in because they're fearful of getting in. But in terms of surgical complications post-op, yes, there's been a huge rise. Lots of patients have had to get more ICU-based care, and they've had to, the work is piling up. So the complications, even related to surgery, are making the outcomes worse.
I see. So is there any emerging, this might be an unfair question, is there any emerging data to show that perhaps an asymptomatic carrier would have just as that as the only, what do you say, causative, having a bad surgical outcome? I think is what is the prevailing question, which might not be easy to answer.
The fact that you're COVID negative does not mean you have a better outcome, and the fact that you're COVID positive will not mean that you'll even have a worse outcome. There have been patients who've got mild variants of the disease, so when they need the surgery or when they have the surgery done, there was actually a very small study done within the trust that they basically showed that patients who had thoracic surgery with COVID and those who didn't have non-COVID had similar mortality rates. So I think it all comes down to how the patient response is. And of course, if you have a very severely ill COVID patient, the likelihood of having surgery is very slim because they might be manifesting and needing more advanced critical care than having that procedure done. We've had emergency surgeries for patients with COVID, but what I've seen is it's like appendicectomies or ovarian torsion or kidectomies. Pretty young patients as well. I don't know the numbers when it comes to hip replacements or issues such as necrosis femur procedures. So it's a bit hard to tell with the geriatric cohort. But for emergency procedures, it will also depend on the patient and how they respond. COVID has been a definite hit.
Absolutely.
Yes.
Okay. Yeah, your answer is very clear. Thank you. Well, we only have 2 minutes left. So there's just questions about sort of contextualizing the scores, risk stratification to our context, simpler tools, how we can adjust them to our context, adjusting them to COVID. Is there hope for us? Is there hope for us, Dr. Maxine?
Nice question. That's the same question my research supervisor asked me. Proframini actually asked, she actually made a comment with the ASOS2 calculator trial when it was published in the VGA. And she says, we're all in this mix of creating nice tools and stratification calculators, but do they work for every cohort group? Do they work for every society? Do they work for every surgical population? And the only way to answer that question is to test and see. That's one. And if it doesn't work, what can we do as experts in our field in that population to make it better? So for example, I remember reading an editorial she made in the BGA regarding ASOS2 saying, it's a wonderful calculator. How about we come up with a way of incorporating it to the WHO surgical safety checklist? And if you look at the WHO surgical safety checklist, the last part, which is for post-op, is a question where the surgeon and the anesthetist are asked, do you think this patient will require more advanced care or more follow-up post-op? And I think we can start from that point. There's a reason why I asked if the apps could be downloaded, because I want to also get feedback from the team and say, okay, I had this patient in my setup. I tried to use the app. I wasn't able to talk to a hematologist. I wasn't able to speak to an endocrinologist. I wasn't able to do this, and I was not able to do that. And from there, then, it creates a thought process of then what can we do to make or to create an app or to create a statistic calculator that would actually work for a Kenyan population in a resource limited or a resource restricted area that would actually highlight the outcomes. So it's a question I'll definitely throw back to the family. Yes. And we need our databases. We need our surgical outcomes. We need to know what we're doing. How are patients doing post-hip replacement? How are patients doing post-orthopedic trauma? How are patients doing post-head trauma? We have lovely numbers and lovely cohort of groups in terms of they give us enough to calculate and, you know, create numbers and percentages. We just need to get on the ground matching and value. This is a plea for residents, you know. It's not always anesthetics that has to be your dissertation. Even as a good observational study on surgical outcomes in your institution would be a great dissertation. And that would be part of the database that people can use to get in a buy-in from surgeons, get in a buy-in from physicians to, you know, be part of the whole change.
Thank you. Thank you, Dr. Maxine. We're running over time. Thank you for this excellent presentation that's generating more and more questions. I'm certain it's unanimous that this was a most informative, interactive, relevant, well-presented, and entirely wholesome discussion. We thank you for your time. Our sponsors, BD, thank you for working with us. Thank you, Maxine. Thank you. Yeah, our sponsors, BD. Yes?
Sorry, before you finish, may I please request the team, if you're interested in anything periop, feel free to just let Angela and Shelmit know. I'm gladly willing to do discussions, and my consultant teams are also willing to have discussions with the family. So,
that's perfect. Yeah, yes, and we'll definitely connect the two of you. Sorry, there's just a mic that's... So, sorry, our sponsors, BD, thank you for working with us, not just in this event, but in our regular clinical spaces. You, our esteemed delegates, thank you for joining us. It's not lost on us how privileged we are to have you join us and learn with us and contribute to this space. KSA Executive Committee, all the organizers for running the CME calendar, KSA members for fronting pertinent discussions and supporting this forum. To Ms. Shelmit Macharia, the faithful KSA administrator who all the time and all the effort she puts into running one successful event after another. Thank you, Shelmit. We have started to upload these sessions on our website, so feel free to log on, but note that when you log on to the prior presentations, those will not attract CPD points. We welcome and invite you to share your preferences as regards the subject matter we tackle. Your questions, your comments, criticisms, and contributions are exactly what make for a rich and rewarding interaction. And so with that, we wholeheartedly invite you to next week's webinar, same time and same place. Good night, everybody.